Well, it's a pleasure. Thank you. Thanks for coming out this morning. It always amazes me. If it wasn't for the scones and the fruit, it amazes me that people get up this early. I'm glad to be here. And I was going to say it's not hard to be the president and CEO of Buckendorf Associates because it's just me and Brandon and Tracy and Jolene. So, I could be vice president and it'd be fine as well. It doesn't matter. I appreciate your coming out this morning. I love this topic of autism spectrum disorders. And I'm going to talk about both autism spectrum disorders as well as some lessons that I've learned that I think transfer nicely to our workplaces and other interpersonal relationships. Let me start with, every year the Department of Health and Human Services puts out their top 20 new findings for the year around this issue of autism. And so they put out their top 20 in 2009. And of that top 20, 9 of those related to genetic research. So that is where a lot of the current research is going around this area of autism spectrum disorders. And then some others that were interesting was there was an interesting medication trial where they found that if kids were on a medication, if they coupled that with parent training, the outcome was a lot better with the kids. So it isn't just a medication that makes a difference in with the kids we work with. It's that plus parent training. Then there was some articles about prevalence and incidence of autism and why it seems to be rising. And then the last one was that children with, of these articles, was that children with autism spectrum disorders prefer looking at people's mouths instead of their eyes. And I remember years ago, one of the physicians in this area that works with a lot of kids with autism, he had this phrase that just has always stuck with me. It's where the eyes are. So you watch your infants, your little kids as they develop, they look at your face and especially your eyes. And little kids at even 3 or 4 months of age learn that where you're looking is where your attention is, and eventually they learn that that's where their attention needs to be because then you're both focused on the same thing. So this issue of where the eyes are and what I'm looking at is very critical, not only in normal development, but as we work with kids on the spectrum, we work on that eye gaze and getting kids to look at us and where we're looking. I appreciate and enjoy Malcolm Gladwell's books. He wrote Outliers and Tipping Point, and his current book is excerpts from a number of articles he wrote over the years, and is called What the Dog Saw. But I wanted to read a little bit of the preface because it exactly relates to this issue of autism spectrum disorders. He was talking about how he went in his dad's study, and his dad was a mathematician, and so he had all these pages filled with figures and numbers, and he said, I couldn't get over the fact, as I looked over all these figures of my dad, I couldn't get over the fact that someone whom I loved dearly did something every day inside his own head that I could not understand. He said, this was actually a version of what I would later learn psychologists call the other mind's problem. 1-year-olds think that if they like goldfish crackers, then mommy and daddy must like goldfish crackers too. They have not grasped the idea that what is inside their head is different than what is inside everybody else's head. Sooner or later, though, kids come to understand that what they're thinking about and what they like doesn't necessarily mean that's what other people are thinking about or they like. And then Malcolm says this is one of the great milestones in human development, this recognition. So why is a 2-year-old so terrible? Now, I'm not sure this is the only reason, but this is one. Anyway, he said, because she is systematically testing the fascinating to her utterly novel notion that something that gives her pleasure might not give someone else pleasure. And the truth is that as adults, we never lose that fascination. What's the first thing you want to know when you meet someone at a dinner party? One of the questions you ask is, what does that person do? Not so much because perhaps you want to know, but we're interested many times in what does it feel like? What would it be like to be that person in their work setting? Curiosity about the interior life of other people's day-to-day work is one of the most fundamental of human impulses. And this is the issue when we work with kids on the spectrum. Those of you who've raised kids or been around grandkids or siblings recognize that normal development, it's this dance between a caregiver, a parent, and a child. So when a child is 2 months old and you've got this little kiddo in your arms and you're hugging him and hugging her, and she or he looks at you and coos, then you coo back. And at the beginning, those are accidental. But over a period of time, the child learns that, this is kind of fun. I coo, they coo, I look, they look. I do something, I look over here, the child eventually learns to look over here. And so normal development is this dance between a caregiver, a parent, and a child, back and forth. And as the months go along, that dance becomes more complex. But even you, as you have a conversation with someone, your spouse, a coworker, an employee at work, your conversation is a dance. And a good conversationalist is someone who makes a comment or asks a question, and then one of the hardest things in the world to do is just wait for that other person to take their turn. And so people that you would find boring are people that haven't learned to make that dance, because they just want to talk about what they want to talk about. And so a good conversationalist says back and forth like this, and you learn it from when you're a little kid. It's, in fact, in my notes and in your notes, I noted that it's this interplay between temperament, and kids all come wired, you come wired with different temperaments. This interplay between temperament, emotion, just how you're feeling that day, and behavior. And it drives this engagement between people. So here's the core issues in autism spectrum disorder. If you were going to read the DSM-4, the Bible that describes all of these disorders, it's these three areas. It's one, it's an impairment in social interaction. And it's things like eye gaze and facial expression. Children learn quickly to read, typically developing kids learn to read facial expressions very quickly. So that you frown, little kids learn to frown back fairly quickly when they're infants. And so kids learn to read each other, especially to read your face. Social emotional reciprocity is when you feel bad, a child can mirror that. So that's one. The second is impaired communication, and that's an impaired ability to use words, but also, probably more important, an inability, or at least a delay in an ability to use gestural communication, like pointing. We don't realize how significant a point is until a child doesn't develop that. Because what a point is I'm saying to you, look at where I am and then follow my point or my gaze. I want to draw your attention to someplace else. And kids learn that they do that same thing, typically developing kids. No initiation or turn take, and then a delayed receptive or understanding of language and use of language. And then the third area on kids on the spectrum is this issue of, we call it repetitive and stereotype behaviors, that kids do something over and over. So little kids that we see in our clinic might do hand flapping. They do this, we call it a self-stimulatory behavior, but this hand flapping that goes on and on like this over and over. Or older children that are more capable, that have language, one of the things that they do is repeat a topic over and over for a period of time, or stay stuck on one topic. So there's the three core areas, three issues that are part of the constellation of symptoms that we call autism. But what really happens in this, or a part of what happens, is that children on the spectrum, as they're developing, instead of blossoming out and engaging with other people, watching your eyes, looking where your eyes are looking, understanding where you point, that's where they need to point, understanding that when you say something, that word, that reference is a symbol that represents something else. And instead, kids with autism begin to become more and more focused on a narrow stereotyped interest. And instead of looking at you and blossoming and interacting with you, they become more and more focused on those areas of interest. And what happens is insidious, because the child becomes more and more focused on this narrow area at the expense of engaging with others. And it's experience that builds brains. So if I watch you and learn that where you look is where I should look, that where you look, I should look at that point, then eventually I get to the point that I'm making hundreds and hundreds of opportunities through the day where I follow your lead. So you look and I look. You make a comment and I react to that. You say a word and I look at that. I say, "Where's your nose?" and I look. And then the child points to his nose. But it's not just that. I might say to the child, "Where's your nose?" and the child points here. And then I say, "That's great. You found the nose. So there's my turn." And then the child points to the nose again, and I say, "You did it again. That was great." And so what happens in typical development is kids quickly learn that this is reinforcing because they like how this feels, this interaction between them and their caregiver. And so a child who's typically developing gets eventually thousands of those interactions a day, every day, from a caregiver, from a sibling, from people in their environment. And so they learn over a period of time that this interaction is both stimulating and they want to do it. They enjoy it. The issue in kids with autism is that the kids as they develop don't get that reinforcement. That this engagement that happens back and forth is not either both stimulating and useful to the kids, and so they become more and more within. It's interesting in our practice, we're seeing, and this is true across early intervention with kids on the spectrum, we're seeing younger and younger kids. There's some excellent work recently on red flags with kids with autism, and so we can at least have some red flags now, things we notice on kids that concern us at 9 to 12 months of age. And so in our clinic, we're starting to see younger and younger kids on the spectrum, and this is what of course, we notice with those kids is that they're not engaged with their caregivers. The other thing that happens, though, in kids on the spectrum is that because there's less and less of this interaction, the caregiver reaches out and smiles and says, "Where's your nose?" And because the child is not engaged, they don't understand perhaps what we're asking them to do, they don't follow that request. And it becomes more and more difficult for a caregiver, for us as parents, to keep reaching out to kids when we're not getting that reinforcement back. When I have a child that's typically developing, I say, "Where's your nose?" They point to it. I say, "Yay, you got it. Where's your ear?" And so kids get this reciprocal interaction that's positive and reinforcing. Kids on the spectrum, this dance doesn't happen because of the nature of autism. And so not only does the child get fewer and fewer opportunities, it becomes more and more difficult for the families, for the caregivers, because they don't get this same positive reinforcement back. So when we see kids on the spectrum, there's a number of interventions that are helpful, and that's one of the ways that research is going now, is what are the most effective interventions? And it's a combination of behavioral interventions and medications of some kids, and there's a lot of them. But the core of many behavioral treatments for kids with autism is we want to reestablish the dance. And so when I see a child that's between 1 and 2 who's on the spectrum, comes to us with a provisional diagnosis of autism, one of the major things that I want to reestablish or establish is the dance. And the dance starts with eye gaze or a sound or a touch, where I get in that child's level and teach the child that the gaze and the reciprocity is stimulating. So I put in my notes, I said reciprocity is when we are sensitive to one another, and it's this dance. It's balanced social interactions. And some of the techniques that we use, the broad areas, are things like, we call it take a turn and wait. It is so hard for us as clinicians or you as a caregiver to take your turn and then wait, because we just want to fill it in. When you're in a conversation with somebody or you're in a group and you ask a question, those periods of silence are so awkward. But the periods of silence have to occur because it gives your conversational partner, your play partner, a chance to take a turn. And so as a clinician or you as a parent or grandparent, when you're playing with your child with autism, one of the things that is very, very effective is to do something. Hold up a toy, blow a bubble, drive a car, clap your hands, whatever, and then wait for the child to do something directed to you. Because that gives the child the opportunity to learn to be an initiator. which is one of the most important skills that we can teach kids, is that they initiate and then somebody responds. So you as a parent or caregiver, you learn to be the responder to that child. So take a turn and wait. Another term for that is circles of communication. That is, I do something and then the child does something and I do something. And what we want with kids on the spectrum is hundreds, thousands of those circles of communication throughout the day. And follow the child's leads and interest. So what we do is systematically, over time, build skills like eye gaze and pointing and joint referencing at something, and teaching kids to request using words or a sign or a picture or whatever system that is most efficient for them, teaching the kids to use that to communicate. So I thought about this idea of autism. How does that relate to you at work? It's the same at work. So in our little company or your big company, two of the most important skills that you can learn are these same things: to initiate and then wait. To say something and let your coworker or spouse or employee say something back. So instead of me being, the big boss or the big spouse or whatever, so that I'm always in charge, to let other people initiate and then respond to that is critical in your home and in a work environment. And the other is this turn-taking. We call it reciprocity. And again, just like it is with kids on the spectrum, in your home it's the same. It's this dance. It's following your eyes. It's following your interest. When you bring up a topic, I give you a present when I say, tell me some more about that. You like, what do you mean by that? That's very interesting. Because the other alternative is, somebody says something, I say, I remember that. I saw that was something I saw a number of years ago. And then I go off and the person says, yes, it's my topic. And this happens with older kids that are verbal with autism. They have their topic and maintain it, forever. So, what have I learned as I work with kids with autism and am in business, and I was at OHSU for a number of years? 3 significant truths. 1, people are more important than projects. In my work setting, I get to work with people all day. I get to work with kids all day. It's work. Some of my colleagues say, want to know the reason why this is so hard? Because it's work. That's what work is. Work is work. And so it's not in, parents come in, or when my kids were little, they'd come in and say, Dad, you just play with toys all day. Look at your room. It's full of toys, little cars and trucks, and you shake them and they move, and, blocks and balls and balloons. I spend my life blowing bubbles and balloons and driving cars with little 3-year-old kids. But it's work, because there's a point to all those things that we're doing. But I've learned over the years that those people that come through the door, those families, those little kids, are critically important. They are worth our lives. It's worth my life to work with families and children. Because people come in, families come in, and I say, how are you doing? I had a mom several months ago that said, I am so scared because I do not know what this means. My child has a disability. I don't know where this is going to end up. So people are important. I need to be an example, not a judge to those families. I mean, when you're out in a restaurant and there's a child that is just raising Cain in that restaurant, tantruming and going on, and you want to go over and say to these parents, don't you discipline your child? Do you want me to help you? They don't need that, because who knows, of course, what went on in their home and what's going on with the child. So instead of being a judge of people, I need to be an example. And the third I put down was give words of affirmation, not criticism. One of the most important things I can do as a clinician when a family comes in to see me is to say, ask them, how's it going? How did the things that we talked about last week, how's it working in your home? And then to say, have them show me that skill we're working on, and then have me say to them, you're doing great. When I saw your child did something, Johnny did something, and you responded to that. That was terrific. I want you to do that more, but that was terrific. And so my responsibility is to be an affirming clinician that says, keep it up. and then to help people specifically know what to do. So I was thinking of an illustration, and I love to read my Bible, and so I thought an illustration would be the woman at the well. Some of you know this story. So there's this lady that came to the well at midday and to get water. So she came at midday probably because she was an outcast for the other ladies because they all came in the morning. So she came at midday, and Jesus was sitting there tired and asked her for water. And it was astounding to this woman because she was a different ethnic group. She was a Samaritan. Jesus asked her for help. He was a man. He asked her for help. He talked to her. And then as I read that story, the thing that I learned from that is that he did not judge her, but over and over asked her questions, brought out her story, and affirmed her. So at the end of that conversation, she wanted to know this person more. She was thirsty, and he was engaging with her. So we are around people who are thirsty and tired and frustrated. And I see that with the parents that we deal with all the time. Frustrated because it isn't working like it's supposed to. And so in my soul, I say, I must be a bad parent. And one of our responsibilities is to help parents realize that's not the case. You have a child with a challenge, but here's what you can do to help that. So Jesus saw her as a person, not a project. And that's how we want to interact with people, either in our clinics or people that we work with in our homes. People are of ultimate worth, and people are worth giving our lives to. So those are my comments, and we have some question Q&A time.
The question is, how old does a child have to be in order to be diagnosed?
Now we see a number of kids now that are referred from a number of places, but we are seeing kids that are now between 1 and 2. When I started 30 some odd years ago, when we saw kids that were 7 and 8 with autism, that was young. But now we see kids of 1 and 2. And what at least our autism team does at OHSU is these young kids that have a lot of red flags, the lack of visual gaze, lack of attending to name, lack of responding to a point, those kind of things. If the clinicians see those kind of things between 1 and 2, they give them a provisional diagnosis of autism. They would say PDD, pervasive developmental disorder, NOS, not otherwise specified. So they would say, our guess is that this child meets criteria for this overall umbrella of an autism spectrum disorder, but on those little bitty kids, it's provisional. And then what at least the OHSU team does is refer those kids out to early intervention services, community services, and the kids get service for a year or a year and a half, and then they come back for a definitive diagnosis. And what it looks like to us is happening is a lot of those kids that we see at 1, with the right kind of services, can make incredible gains in that period of time. And some of those kids no longer meet criteria for an autism spectrum disorder. So definitive diagnosis is probably in the 2s, but again, it depends on the child and the team's expertise. So yeah, good question.
So what's the range and prevalence of the disorder?
Yeah, that's a really good question, because those of us who work with kids with autism have noted this rise in both prevalence, which is how much in a population, how many children or people have that disorder. So there's been a rise in prevalence and also incidence, a number of new cases that pop up in a year. And there's certainly, as you read your newspaper and the literature, there's been an increase in the number of children diagnosed with autism. And it's probably a combination of those kind of factors, because that was well said. Certainly, there's a lot more awareness of autism. I mean, you can't read a newspaper or look in a magazine without reading an article about autism. So there's a lot more awareness of it. And so people, it's just on their radar more. And the other thing is there's this called diagnostic substitution. And so kids that used to be diagnosed one thing, some of those kids are now diagnosed with autism spectrum disorder. So there's that issue. But there certainly are a lot more kids that we're at least aware of. And another is because we're seeing kids that are younger and younger. There's a lot more kids that we're aware of that have autism spectrum disorder. So it's probably a combination of all those things. Yeah, good question.
Question is, how do you train the parents?
It's hard because we as parents and grandparents are not very trainable. That is really a good question. And you train parents by giving families, by giving parents small steps that they can do that work. I mean, if I were to say to a parent, you know, do this and this and this and this and this, and you've got to do all these by next week, it's overwhelming. But if I say to a parent, okay, this week, I want you to work on this one thing. And then I show a parent how to do, now watch, this is what it looks like. And then I let a parent try that. Okay, this week I want you to do better at you doing something and then waiting for your child to take a turn. So I blow a bubble. We go through gallons of bubbles at our office. So I blow a bubble, and then the child looks at the bubble. And then I wait for the child to do something back to me that says they saw that, or they responded to that, or they want to play with that. I wait for the child to do something directed back to me. So I blow a bubble, there it goes, and then the child pops it or it pops, and then I wait. And maybe all that little kiddo's got is a glance back at the bubble jar or me. Well, I read that glance back as a communication, and I say, oh, more bubbles. There's my turn. So the child took their turn, then I take my turn. Oh, more bubbles. And then I wait. Oh, as a clinician and parent, right then you want to say, oh, you want bubbles? I can do more bubbles. Here, let me take the lid off, and I'm going to do more bubbles. Now watch. I want you to do. See, that's what we want to do. The kids don't hear that. They don't need that. I say, oh, more bubbles. And then oh, it's so hard to wait. So then I wait. And the child looks or makes a vocalization or points or something. And so I need to send that same skill home with parents. That if that's what we targeted that week, is I do something and then I need to wait for the child to do something. So absolutely, parents are teachable, even grandparents are teachable, and as we clinicians are teachable, but the thing that we need to teach people is that they can be effective in these little things that they're doing. Yeah, good question.
Is Asperger on the continuum?
Yeah, Asperger's syndrome is a fairly new diagnosis, established diagnosis, but Asperger's syndrome are typically kids who are a lot more capable, who have a lot more skills. And right now, the diagnosis for kids who are Asperger's syndrome is that they certainly fit the autism spectrum disorder, but they are kids who do not have a delay in understanding and use of language under 3 years of age. So kids that have a delay, say by 3 years of age, are not using language or understanding language like they should. Even if they're very capable as they get older, they would not meet criteria for Asperger's syndrome. But kids whose language skills at age 3 are within normal limits, if they then meet the other criteria for autism spectrum disorder, then they can meet criteria for Asperger's syndrome. So it's typically kids who have a lot more skill, but still have those core issues around relatedness and then stereotyped and repetitive behaviors. I mean, we see older kids with Asperger's syndrome who have an interest in trains. I mean, those of you who know Asperger's syndrome, or an interest in the solar system, or in reciprocating engines, or in the temperature of the 1,000 closest stars. Kids have these prescribed stereotyped interests that are fascinating, but they're not very useful when you're trying to play with kids on the playground, because they don't want to hear about the solar system and how fast the planets revolve around the sun. So that's a good question.
So how do you interact or give suggestions for somebody who's a little older in their 20s?
Yes. Yeah, it's interesting, isn't it? We tend to pathologize everything. So, you meet somebody out in the street who doesn't look at you and say, oh, I know what you are. You are, whatever, fill in the blank. But Skip, that's a good question because you give a present when you interact with people. And your present is you give them your presence. So you ask a question, and then they say something, and you ask a follow-up question. Now, with people who are not very reciprocal, who just want to go on and on and on, especially if they're in accountability mentorship relationship with us, we do them a favor by helping them learn to be reciprocal. So to eventually take them aside, or as you're meeting with them, and say, one of the things that makes it difficult for me to build a relationship with you is that you don't share the interest or the topic very well. So let's practice, because see, I noticed that, so your coworkers and your employer and your employees notice the same thing. So let's practice on you asking questions of others. And we're teachable on, on those characteristics. I mean, we can learn to do that, but on some adults, it takes some work. So that, again, that's what makes a good listener, is that we teach people to ask good questions. What'd you hear about that? What'd you think the other day? So that, and a lot of times we do that in a role play, situation. So I teach people to ask good questions so that it's about the other person instead of all about me. So, good question.
The question is, how do you coordinate the care? Who else is involved in coordinating?
Yeah, and well, certainly the best care is a team. And so when kids are preschoolers, we always refer them to the early intervention program. Every county or group of counties has those programs. And it's certainly best if the child's primary care physician is at least the head of that team or involved in that team. So, certainly the child's physician, the early intervention program, and then, for instance, at a site like OHSU, their autism team, when we see kids there for evaluations, it's a clinical psychologist, it's a developmental pediatrician, occupational therapist, and a speech pathologist. That's how that team is put together. And then a parent advocate. Some teams have a social worker involved, because it's not just working with the child, it's working with the family unit, the family dynamic. Because raising a child with a disability, as some of you know, far more than me, we don't have a child with a disability. When they were teenagers, I thought they had a disability, but then they passed past that, and they've grown up pretty well. But those of you who raise kids with disabilities, it's really hard. And there's so much tension that can occur. It doesn't have to, but so much tension between spouses, between caregivers, between, grandparents. If you would only, so here I am as a grandparent. Well, you need to, I tell you, a parent that has a child with a disability doesn't need that from me as a grandparent. They need help. And so it's a team of people working with those kids, because it isn't just an isolated issue, it's the whole family dynamic that's an issue. So.
Thank you, Bob. Wasn't that a great topic?
Yeah, thanks.
Please give another welcome to
Thank you. Yeah, thank you.
you.
Thanks for your time.